Good afternoon, everyone. I will be discussing a rare case report of meningioma in pregnancy presented with blindness, and she was managed successfully with multidisciplinary team approach. Meningioma accounts for 30% of the intracranial tumors, and it has higher incidence in female as compared to the male. Peak age of incidence is around 45 years of age, but 30% of the women with meningiomas are in reproductive age group. Incidence in pregnancy is 1 to 4.5 per 1 lakh pregnancies, but it shows aggressive nature in pregnancy due to hyperdynamic state as well as hyperhormonal state. Plantar sphenoidal meningiomas represent 5 to 10% of the intracranial meningiomas with female predominance. Now coming up to the case summary. A 34-year-old primary gravida female with a history of primary infertility since 13 years. She presented in ANC OPD at 33 weeks period of gestation with chief complaint of sudden progressive painless diminution of vision in bilateral eyes since 3 months. She had no history of fever, headache, nausea, vomiting or generalized weakness, or there was no history of raised BP preceding diminution of vision. She was admitted from OPD for further workup and management. Coming up to the trimester-wise history, after the primary infertility, patient conceived on ovulation induction. In second trimester, there was a significant history of hyperemesis gravidarum at 4-month period of gestation, for which patient was admitted at GTB hospital and managed medically. During the course of hospital stay, patient underwent anomaly scan in which fetus was diagnosed to have echogenic bowel, for which patient was referred to AIIMS to fetal medicine department for invasive testing, which came out to be normal. Patient developed painless progressive diminution of vision at 5 months period of gestation, for which she consulted in a private hospital and told to have normal ophthalmic tests. She again came to AIIMS OPD at 8 months period of gestation for routine ANC visit. During her visit, we noticed there was different abnormal gaze, but on interrogation, she did not complain of any vision loss. In suspicion of any abnormality, we referred patient to for ophthalmic evaluation and MRI brain. After investigation, patient was diagnosed subsequently to have meningioma, so patient was admitted for further investigation and plan of management. On admission, her general condition was fair. Vitals were stable. In CNS examination, motor power was 5/5 in all the 4 limbs. There was no sensory deficit. On per abdominal examination, uterus was corresponding to 32 weeks period of gestation, and fetal heart rate was 144 beats per minute regular, and uterus was relaxed. On ocular examination, bilateral pupil was normal in size and normal in reaction. There was a relative apparent pupillary defect in left eye, and visual acuity in right eye was finger counting at 1 meter distance, and in left eye there was only perception of light. However, there was no field defect in perimetry. On ophthalmoscopic examination, fundus was within normal limit. Her routine antenatal investigations were within normal limit. On ultrasound done at 32 weeks period of gestation, suggestive of fetus with stage 1 FGR with normal Doppler. Now I would like to call upon Dr. Spooky for.
So for this patient, we have 2-point studies. The first one is a contrast enhanced CT followed by a non-contrast MR. So in this axial CE-CT free format, we are able to see that there is a well-demarginated lobulated lesion of a solid mass, which is occupying the suprasellar region, which shows homogeneous avid enhancement and with a central area of hypodensity within. There is mild perilesional edema in the right basifrontal region. The lesion otherwise appears to be an extraaxial lesion. These 2 vessels are basically the MCA, which has been displayed and splayed by the mass. Whenever encountering a suprasellar or even a parasellar mass, it is important to rule out a sellar extension of this lesion. And in the sagittal reformats, we see that the sellar size appears to be normal. Further confirmation will be seen on MR image. There was no extension of this lesion into the sphenoid sinus. On the T1 non-contrast MR image, it appeared to be iso-intense, and on the T2, it appeared iso to mildly hyperintense. The edema on the right basifrontal region is also well seen. Again, the splaying of the terminal ICA branches and the MCA branches were also seen on this MR, which is evidenced by the displacement of these flow voids. There was no extension of this lesion within the sella, although the stalk could not be separately seen, likely compressed by this mass. And the lesions showed to have a broad base towards the dura on the planum sphenoideum. The optic chiasm as well as the optic nerve were seen to be compressed by the lesion. However, there was no obvious intracanalicular extension. To summarize, in a 34-year-old pregnant female, we have a supracellular mass which shows homogeneous avid enhancement and is extra-axial with significant compression of the optic chiasma as well as the optic nerve and splaying of the terminal branches of the ICA as well as the branches. So our first differential would be a meningioma. Looking at the signal intensity, other differentials to be considered would be lymphoma or leukemic deposits as well as LCH, but they are very unlikely given the clinical scenario. So the prime differential of concern remains a meningioma. I would like to hand over to Dr. Saima for further discussion.
Following admission, multidisciplinary team approach was sought for this patient involving obstetrician, neurosurgeon, anesthetist, critical care specialist, ophthalmologist, and pediatrician. Following admission, patient developed persistent headache and vomiting and further diminution of vision, which was suggestive of raised intracranial pressure. On fundus examination, there was no signs of papillary edema, but on visual acuity, in right eye, finger counting was present at a distance of 2 feet, and in left eye, even the perception of light was negative, which was initially present at the time of admission. So, since we are dealing with a very challenging situation in which we are dealing with a case where women conceived after 14 years of infertility. She is elderly gravida, she is 34 years, preterm in gestation, and her meningioma causing significant diminution of vision. So our first and foremost dilemma is what should be the timing of delivery, whether we should deliver the patient urgently and giving her the risk of prematurity, or wait until the fetal lung maturity or till the steroid cover. Since the clinical condition of patient deteriorated during such a short period of time, so the second most important concern is neurosurgical intervention and its timing, whether we should perform neurosurgical intervention before the delivery, simultaneous with delivery, or after delivery. And further, the most important consideration would be the mode of delivery, whether we should go for vaginal delivery or a cesarean section. Since in our case, there is a features which was suggestive of raised intracranial pressure, which mandates the need for cesarean section. So neurosurgery consultation was done. Patient was started on medical management. She received injection dexamethasone for fetal lung maturity as well as for reducing brain edema, and injection levetiracetam for seizure prophylaxis. After considering all these important points and need for urgency of neurosurgical intervention, the consideration that our nursery is capable of providing care to the baby born at 32 weeks period of gestation after DEXA cover, a plan for emergency LACS was done. This patient was delivered by emergency section under general anesthesia, which was uneventful. Patient was shifted to ward. She did not require any ICU care. Patient delivered a female baby of weight 1.6 kg. Her Apgar score at 1 and 5 minutes was 9, but baby was shifted to an ICU in view of transient tachypnea of newborn and prematurity. Now, I would like to call upon Dr. Abhishek from anesthesia department.
Thank you very much. Okay, so I got a call on the morning of the surgery, 10th February. Then when I saw the patient, there were features of diminished vision. Patient was having severe headache and vomiting. There was one episode. When we had seen the patient 3 days prior, when we had done the primary PAC, that time patient did not have any of these features. Only the vision was diminished. But on that particular day, she was having this, the headache was very severe. So we went with the assumption that patient is having increased intracranial pressure. So because of this, we chose the patient, we chose general anesthesia with endotracheal intubation. So in this patient, we had initially tried to get a consultation again from the neurosurgical point of view. However, because of the emergent nature of the surgery, we planned ahead and we got a bed in our ICU as a backup in case patient had to be shifted. For headache, paracetamol was started, and as a seizure prophylaxis, levetiracetam was started just on that particular day. So here, considering we had two major concerns, one is raised intracranial pressure because of our intracranial mass, and the other one is pregnancy. So a pregnant patient is, from anesthetical point of view, is altered physiology. So whatever we think from a normal patient is slightly different for a pregnant patient. So because of these major considerations, we chose with general anesthesia with endotracheal intubation. After proper pre-oxygenation, we gave lignocaine to blunt the intubation response. Then induction was just general standard with propofol and choline. Nothing significant. Everything was well controlled in the surgical intraoperative settings. And for analgesia, we gave a tap block and fentanyl and this thing. So after the patient was extubated, patient surgery was done, we extubated and we shifted in the recovery room. Patient was uneventful. Thank you.
In postpartum period, patient did not have any problem regarding obstetrical point of view. She started breastfeeding immediately in postpartum period. However, her raised ICT was resolved, but she continued on medical management. But her visual complaint still persisted. So on postpartum day 10, patient underwent neurosurgical intervention. Now I would like to call upon Dr. Nidisha, SR Neurosurgery, to discuss the case.
Good afternoon, everyone. I'm Dr. Nidisha, and I'll be talking about the neurosurgical management in this patient. So she was a young lady who presented to us with progressive vision loss. And on imaging, we found that there was a meningioma which was centered on the planum, thus establishing the diagnosis of a planum sphenoidal meningioma in a pregnant patient. Now, since this patient was losing her vision, we found it prudent to operate on her as soon as possible and to decompress the optic nerve. Because the damage to the optic nerve, once set in because of the mass effect of the tumor, is more often than not irreversible. But we were conflicted whether to operate on the patient first or whether to get the baby delivered first. So in this case, the patient underwent an emergency LSCS at 32 weeks. She was started on preoperative steroids for fetal lung maturity. And then in the postpartum period on day 10, she underwent the neurosurgical intervention. Now, all throughout, the visual acuity of the patient was closely monitored and it remained stable. Had the visual acuity worsened even by the slightest bit, we would have taken her up for a surgery immediately. But since it remained stable, we decided to wait until postpartum day 10 for the hemodynamic changes that occur physiologically in the postpartum period to settle down before we subjected her to a major intracranial surgery. When dealing with these patients, the surgical options available to us are to perform an expanded endoscopic surgery or to go in transcranially. Now, in this patient, if we look at a scan, the tumor is abutting the internal carotid artery laterally and it's playing the ICA bifurcation bilaterally. Also, all the important vessels like the ACA, the MCA, the recurrent artery of Hubner are in and around this area in the vicinity of the tumor. In fact, they were encased by the tumor. And in such cases, this lateral area is particularly difficult to access through endoscopy. Also, in endoscopic cases, it mandates the insertion of a lumbar drain post-operatively that would interfere with the post-operative rehabilitation of the patient for at least 4 to 5 days. Thus, to prevent all of this, we decided to go in transcranially in this patient, which also happens to be the gold standard treatment of choice for these patients. So just to highlight the important surgical steps, here we can see the tumor which is being dissected of the surrounding structures, the ipsilateral and the contralateral optic nerve. It was an extraaxial lesion completely and it was easily dissected of the optic nerve. That's the intracanalicular portion of the tumor that is being removed. This is also the portion of the tumor which is responsible for the patient's visual deficits. The optic canal was de-roofed and the optic nerve was adequately decompressed. That's the dura over the planum being coagulated, thus achieving a Simpson's grade 2 excision of the tumor. Post-operatively, this is the post-operative scan of the patient. It shows a good resection cavity with other expected post-operative changes. In the post-operative period, the patient did very well and her vision had dramatically improved, and on post-op day 3 itself, she was able to see from both her eyes. Thank you.
Good afternoon. So, the challenges which we faced during management of this patient were the patient was having pregnancy and having meningioma and associated with vision loss. So, before discussing the management, we need to know how this meningioma causes the vision loss. So, meningioma is the slow-growing tumor which arises from the meninges covering the brain and the spinal cord. And according to the area of the origin, they can be termed as olfactory, supracellular, paracellular, or sphenoid. Those tumors which arises from the anterior chiral fossa, or those who are in the vicinity of the sella turcica, they have more propensity to cause visual disturbances by virtue of these tumors, because they are in the vicinity of the optic nerve and the optic chiasma. When they grow, they causes compression over the optic nerve and the optic chiasma. By doing so, they can cause visual disturbances and even the vision loss. So here is the base of the skull. There is the sella turcica. This red area is called tuberculum sellae, which is the anterior wall of the sella turcica. This blue area is the planum sphenoidale, from which in our case tumor arises. This yellow area is the olfactory groove. So the area between this blue and red is called the chiasmatic groove. Here lies the optic chiasma. So when the tumor grows from the planum sphenoidale, it can grow and it can push the optic chiasma dorsally and caudally, so causing the blindness. It has been seen in various studies that during pregnancy, because of the vascular engorgement and because of the retention of the fluid, the tumor size increases. And it has also been postulated that during the pregnancy, there is increased expression of progesterone receptors over these tumors, which might accelerate the growth of the tumor during the pregnancy, so further rapidly progressing the symptoms of these tumors, causing the blindness. So there is a study by Malari et al. They presented 3 such cases who presented during the pregnancy with such meningioma causing the vision loss. They also reviewed the literature for the similar cases, and they found out 19 similar cases. And in total 23 cases, they found out that the vision loss was there in almost 20 cases. And out of these 22 cases, 11 were operated during the pregnancy itself, while rest of the patient, in 9 patients, they were operated during the postpartum period. And the visual outcome was improved after the neurological intervention in 13 cases, which is a very good number. And the visual outcome remains stable even after the surgery in rest of the 3, and rest of the studies, they didn't report the visual outcome. One more study by the Kanan et al., they assessed the meningioma in pregnancy. They retrospectively studied 18 pregnant women, and all 18 pregnant women were multiparous, and the meningioma was diagnosed during the 2nd and the 3rd trimester of the pregnancy. They showed that out of these 18 pregnant women, the visual impairment was seen in 12 patients, and the site of the tumor was tuberculum sella in 8 patients, and sphenoid wing were present in the 4 patients. The visual impairment out of these 12 patients, the vision was severely impaired in 7 women, and this vision was significantly improved after the neurological intervention in three patients, and while it was further worsened in 2 cases after the surgery. The visual impairment in 5 mildly impaired vision improved spontaneously without any surgery after the delivery in 2 cases, and it was improved after the delivery with surgical intervention in 1 case. Although there are case reports of visual improvement after the delivery in few cases of pregnancy with meningioma who presented with a visual loss, but since this condition is very rare, so we don't have any guidelines how to manage such cases in the pregnancy. So we take extrapolation from the guidelines given by the European Association of Neurological Oncology, which are given for the diagnosis and treatment of the meningiomas in non-pregnant patients. According to these guidelines, the surgery is mandated if the patient is having symptoms or mass effects, or if the patient is willing for the surgery, and if the patient's condition is good, then we go for the gross total resection of the tumor and we send it for the histopathology. And further management of the patient is according to the histopathological grade of the tumor. A article published by Galal et al., they look for the determinants of post-operative visual recovery in the suprasellar meningiomas in non-pregnant patients, and they found out that the extent and the duration of the visual symptom, size of the tumor, vascular adherence are the prognostic factor. So if the vision is severely impaired and the duration of the symptoms are more than 1 year, or if the size of the tumor is more than 3 centimeter and it is adhered to the vessels, then these are the poor prognostic factor for the visual recovery even after the neurosurgical interventions. So the general rule for the management of such patient during the pregnancy are: surgical intervention should be avoided during pregnancy because of the increased risk of the mother and the fetus during the pregnancy, during the surgery, and also the surgery may be postponed until postpartum, as long as the lesion is not about to cause irreversible neurological deficits. The increased intracranial pressure should be treated medically until fetal lung maturity is reached. But a pregnant woman should never be denied indicated surgery, regardless of the gestation age. Though if possible, non-urgent surgery should be performed during the second trimester. What are the indications? The indications of urgent neurological interventions are the suspicion of malignancy, active hydrocephalus, signs of impending herniation, and progressive neurological deficits. And the medical management in the form of corticosteroid is given to decrease the edema of the tumor as well as for the fetal lung maturity if the fetus is preterm. And the anticonvulsant therapy is given to prevent the seizures. Folic acid and vitamin K is supplemented along with this, and mannitol to decrease the intracranial pressure should be used with caution because it can cross placental barrier and it can adversely affect the fetus. In our case, there was a severe progressive visual loss which warranted the neurosurgical intervention. Fetal lung maturity was achieved with the antenatal steroid therapy, and with the good support of NICU, we took the decision for preterm delivery by cesarean section to avoid the surgical risk to the baby. And after cesarean section, timely neurological surgical intervention led to the complete recovery of the vision and the excellent feto-maternal outcome. So, to conclude, in our case, the short duration of the visual complaints, small tumor size, and timely neurological surgical intervention lead to the good prognosis of the patients. Thank you. Now I call upon Dr. Aparna Sharma for the further comments.
Thank you, Dipali. Like ma'am said, today seems to be the day of the brain tumors. So I would just say that meningioma is not rare, but meningioma in pregnancy is definitely rare. Meningioma causing visual loss is much rarer, and meningioma causing visual loss which actually recovers and improves is definitely rare. There are not many cases which have been reported in literature, and definitely which are less than 10. So before I open the case for discussion, I would just request if Dr. Vivek has some comments because he was the neurosurgeon involved.
I don't have many comments, but I see there are many students here. So I can just tell you what you shouldn't be doing, how not to be a neurosurgeon. So this patient, when she walked into our clinic, what usually happens in neurosurgical clinic is the resident will see the patient and then the resident will bring to the neurosurgeon. And as neurosurgeons, we are accustomed to spending time in operation theaters. And our OPDs are quick like this. So this fellow comes to me and says, plenum sphenoidal meningioma, sir, surgery. I said, yes, surgery, go ahead. Give date for surgery. And then I find this patient is still standing there in front of me. And I asked, what's the problem? The husband says that she's pregnant. Now, what to do? I said, how many weeks pregnancy is there? He says 30 weeks. I said, surgery, go ahead with surgery because she's losing vision. And for us, I mean, if you have lost vision, we will not be able to bring it back. So I thought, oh, no, nothing doing. I mean, this is a tumor. Surgery has to be done as quickly as possible. So please go ahead with the surgery. And still after 2 minutes, I found he's standing there. Now, if you look at the evidence that is existent in literature, it will, like she said, that surgery should be done as early as possible. But as young medical students, you must understand that whatever is the evidence that you find in literature, it's immaterial because everything has to be tailored to what your patient requires. And then I inquired, what's the problem? And she said, after 13 years of infertility, now she's pregnant and she wants the baby. What is to be done? I mean, as a surgeon, you want to save vision. She wants to save the child. What do you decide? And then the husband asked me, how many days it will take you to do the surgery? How quickly you can admit? And unfortunately, we have a very, very long waiting list in our department. And if you want to admit a person who is losing vision, it still takes us 4 to 5 weeks. And I thought, now what is to be done? I said, okay, you go to the gynecology department, you meet doctors there, you ask what is their advice, what do they tell you? And to my utter surprise, the graciousness of the Department of Gynecology, I got a call after maybe 2 weeks from them that she has been admitted there. So the first thing that I want to tell you is take proper history. Don't forget to take the proper history. If you don't do that, you will end up making a mistake. Harsh decision, quick decision. It won't help you. And then Dr. Dipali, who was seeing the patient, she will call me every I think 48 hours, she will call me, patient is having headache and vomiting. And headache and vomiting, as young people, you will realize it is a sine qua non of raised intracranial pressure. Now again, this tumor, which he said small, it's not small, ma'am, it's big, but not very giant in size. It usually doesn't cause this problem of headache and vomiting. So what we thought is to have a proper examination. And in one of her slides, she wrote that she is not having papilledema. Probably the headache and vomiting was not because of raised intracranial pressure. And that is why we decided to postpone the surgery, not based on scans, not based on literature, but on pure clinical judgment that we decided to postpone the surgery, let the baby be delivered first, and then we will intervene. And in the meanwhile, we just kept on monitoring her vision. Is it still deteriorating? And it was stable. Now, the dilemma that these people had was whether we should go for the vaginal delivery or the cesarean section. That also we searched the literature and we spoke with people who are senior to me in the department. But there was no clear consensus. It was still debatable. When she's not having raised intracranial pressure, why to subject a person to the cesarean section? But then we thought, I mean, there is no point in taking risk because if a person is going through normal vaginal delivery, obviously that person will strain, and even if there is mild raised intracranial pressure in a person, and that is why we thought maybe you should go ahead with the cesarean section. Once the baby was delivered, person was hemodynamically stable, and then only we operated. I think the surgical part is beyond the scope of discussion here because all of you are young. Whenever you come to our department, then we will teach you. And with this, I would like to hand over the mic to Gynaecology. Thank you.
I would request ma'am, Dr. Neena, Dr. Nita Singh, Dr. J.B. Sharma. Sir, any comments? So, so if there are no comments, I think we close the discussion, sir. Thank you.